I think they could have put a Kiwi accent on that. Did you all get that recording in progress? Hey, so kia ora koutou, ko Fiona Graham taku ingoa. It's a privilege to be here with you today at another one of our fantastically attended lunch and learn sessions offered to you through the Paediatric Society of New Zealand and the Child Disability and Development Clinical Network. So there are many of us here today from that network where we work very hard around advocacy and development of support and resources to children and youth developing differently, and those who work to support them. If you'd love to get involved, just get in touch with myself, Fee Graham, Estelle Bora, Jane Hamer, or Pari Mala, who are here with us today. We'll put your details in the chat box. Today we have a special guest, Sam. Where did William come from? Sam Murray, and fantastic that you can join us today, Sam. Sam is a policy analyst currently working in policy and document support, which I'm sure is a lot more exciting than it sounds, at the Southern DHB. And he's worked in the child health and disability sector for quite some time, doing that hard work of analysing policy as it comes out and looking at the data that shows trends in the impact of policy, be they intended or unintended consequence. And so Sam has published quite a bit in this area in the peer-reviewed literature, and he's going to share with us today some of what he's found about patterns of policy in relation to equity in the New Zealand context. So Sam, hand over to you and we'll open it up for question time after this. This is the first month where we are moving to our alternate month speaker. Sam, you're our first speaker in this new format for the Lunch and Learns. Next month, we're going to be running a facilitated discussion on how we can make changes or look at our own processes of care where we're working or whatever system that we're involved in for implementing the findings that Sam is sharing with us today. So you might want to take particular note as Sam goes through his presentation around what you could do differently or your service could do differently, and then we'll have some group workshopping around that in next month's Lunch and Learn. So no pressure, Sam. I'm sure you've got all of that sort of stuff embedded in your presentation as it is. So over to you now. I'll just stop sharing.
Cool. Kia ora, and thanks everyone for coming. William's actually my middle name, so that must be where it came from. You probably saw it in my email address. I had to use my full name because Sam Murray was taken. Right, let me know if you can't hear me. That's always the first trick. And the second trick is we are going to share a PowerPoint. Let's see how it goes. All right, hopefully you're seeing a PowerPoint. Is that? Yep, I've got a thumbs up.
Yep.
Perfect. Okay. Oh, so we're just starting with hopefully many of you can guess where this is. This is, of course, Dunedin, where I'm from. I'm currently actually, it's just slightly obscured by just slightly on the right there in Whakari Hospital right now. So that's where I'm coming to you from. And my house is actually somewhere around there, if you can see the cursor. But yeah, this is the hill. I was going to say mountain, but Wikipedia tells me it's a prominent hill. Near me, this is, of course, Flagstaff up here. Beautiful view. All right. So we're going to be talking about ethnic inequality and access to disability support. I do have a little disclaimer just there, just letting you know that these are my personal views, not necessarily the views of Southern DHB, A Better Start, or CCS Disability Action. Hopefully I won't see anything that they disagree with anyway, but just there's the little disclaimer there. Yep. So I'm from Dunedin. Oh, here we go. We got "You are not telling me anything." That used to be what my grandmother used to say to me when I was a child. She's one of these nurse matrons, and whenever I would go and tell her something, she'd say, "You're not telling me anything," which I think shaped my desire to then try and go out and find something that would not get that response. But I've just got that there because I just want to let you know I'm hopefully not here to tell you how it is. What this evidence really is hopefully a glimpse at the wider context. And the aim is that it's going to have a two-way relationship. Hopefully, it might help inform some of the things that you're seeing, but of course, some of the things that you're seeing and experiencing should also inform how we look at this data, what data we collect, and how we frame it as well. So I just thought I'd throw that in there. All right. So we have a history. I do have plenty of links at the end, including there's two very good research reports looking particularly at that the Waitangi Tribunal has commissioned, looking as part of the health inquiry, looking particularly at disability and looking at the history. And I think it's fairly fair to say, very fair to say, that we have a history in which Pākehā beliefs about disability have dominated disability policy and support. And this has included imposing Pākehā beliefs about disability on Māori and Pacific people. And I'll also say, despite the rhetoric, and I agree with a lot of the rhetoric, some parts of the disability system are very old and barely reformed. Quite a considerable chunk of the disability, what we think of as current disability supports, were actually designed in the mid-70s, 75, 1978. This is the disability allowance, the child disability allowance, carer support, and actually public building access too. They all come from that period there. And a lot of them haven't been reformed. The child disability allowance has pretty much only had a name change and infrequent inflation adjusting. That's not perfect. Similarly, the disability allowance, the only real changes have been to place more restrictions on it. So in the 90s, it used to be technically available for one-off costs, and that was changed, so it's only available for ongoing costs now, and preferred suppliers, that sort of thing. Learning from the past. So before we get on to the evidence, I did want to go through an example that has helped me think about my practice in the policy space, and hopefully might help you. And this is actually from one of those Waitangi Tribunal research reports. So for those of you who don't know, my former organisation was CCS Disability Actions, founded in 1935. And about 4 years after that, they made quite a serious effort to try and do outreach to particularly reach Māori disabled children in their whānau. So this involved getting branches to set up separate accounts, translating a lot of material and sending people out there. The aim was to educate Māori parents about the child's impairment and encourage them to access the support that was available and to come in, which is not a million miles off what people might do now. There was limited success in this, according to the reports from CCS at the time. Now, what then happened though, which I think is probably the more important part to learn from, because, you know, there was a gulf of understanding at that time. There still is gulfs of understanding between different communities, different sections of society. What they did though, unfortunately, rather than look at what they were doing, they had a tendency to then blame Māori whānau. And some of the things they blamed them for seem a bit odd to us. They blamed whānau for not having a sufficiently negative view of impairment. In the emotive language at the time, they talked about Māori whānau would tolerate disabilities that Pākehā would have recoiled in horror at. This kind of language that was very common with the kind of moralizing aspect and the kind of negative approach to disability that really predominated a lot of thinking and support at that time, and also refusing treatment, refusing to come in. And we are, of course, talking about the birth of the institutional era, well, an expansion of the institutional area, I should say. So yeah, looking back at it now, we can actually see that those their reasons for rejecting some of that support are very rational. And in fact, looking back at it, we might even say that they were on the correct side of history. So the lesson here is not that this outreach, and I mean, you know, I have to give full credit. We are talking very early days here, less than 4 years after the organisation was founded, they embarked on this. So that is impressive. But the lesson here is not that they got it wrong. I mean, that's almost inevitable with gulfs understanding, but the response, instead of critically thinking about what they were offering, how they were offering it, and who was offering it, they blamed people in those communities and society for not getting with the program, for not falling into line. So I think that's an important lesson to think about now. And look, I'm sure those people were good people and they were creatures of their time and they would have been smart people, but we are also creatures of our time. So I guess that's something if take nothing else away from this, try and have a think about that. It certainly, has helped me to think about that. How do you respond when you're not seeing the diversity, when you're not able to reach communities, when outreach programs fail, when initiatives fail? How do you respond? Do you critically examine what happened, or do you perhaps subconsciously maybe blame people from other communities for not conforming to how you would like them to act to access support? I will say today that CCS Disability Action has very strong Māori leadership, partnership and Māori development, and they're not paying me to say that anymore, so you can have a bit more faith in that. All right, so should we get on to what we actually did? So this is a project we did with A Better Start, which is one of the National Science Challenges, and I worked with two very talented researchers, Nick and Dr. Jessie. We kept the project, and there's a link to the report at the end, we kept the project quite small and focused. We did actually do quite a bit of background work, and we wanted something that would be something quite short that could be outputted and used by the community. So this, yeah, so as alluded to, I have done a few peer-reviewed things. This particular one wasn't aimed to do a peer-reviewed publication though. This one was kind of a proof of concept. A Better Start hadn't done many research projects like this, partnering with NGOs, so they really wanted something quite manageable. So we looked at children and young people aged 6 to 18 in the 2016-17 fiscal year. I'll go into why we chose a year a couple of years back in the past. The reason we chose 6 to 18 is we did have a look at some of the data around when children entered some of these programs, and particularly for the ongoing resourcing scheme, there was quite a lot of people entering in that age 5 age range, which in itself probably deserves quite a lot of investigation, because you would hope that many people who qualify for the ongoing resourcing scheme, their needs should have been picked up in early childhood care or through early intervention services or child development services for that matter as well. But yeah, we really found after the age of 6, there was some entries after that, but they really dwindled. It was really going up to 6 that there's a lot of entries into the ongoing resourcing scheme, which does spoil the surprise. My last bullet point, what did we do? We compared the Ministry of Health's Disability Support Services with the Ministry of Education's ongoing resourcing scheme. For those of you who don't know, and the name is incredibly unintuitive, it's one of the worst names I've got to say for the many support we have. The ongoing resourcing scheme is a scheme aimed at supporting disabled students with high and very high needs in a school setting. It's a terrible name. It's completely bureaucratic, the name. The reason it says it's ongoing is because it's something that sticks with them throughout their whole schooling experience, as opposed to a one-off. Don't ask me why it's a scheme though. I'm not aware of any other support that's called a scheme in this context. And we also compared both to the estimated resident population, which is to say we looked at children and young people in that age range at that time as in the whole population, if that makes sense. Now, how do we do it? We used the integrated data infrastructure, which people often call the IDI, which is a way to combine a lot of data sources, administrative and also the census and also household surveys. One of the reasons we wanted to do this is, well, it allowed us to get the estimated residence population, but it allowed us to use something called source ranked ethnicity data. So I've done a lot of these comparisons before, but a big problem is each of these types of support have slightly different categories around ethnicity. They collect ethnicity in a different way. So you're always going to get a bit of a problem that some of the difference you see might just be because of differences in how ethnicity is collected. Source ranked ethnicity data is much more reliable and is managed by Statistics New Zealand and uses the best available source, usually the census, for each individual person. So this allows us to get much more reliable and comparable data. And we also use total responses. So what that means is if someone selects more than one ethnicity, we report on all of those, not prioritize. We just use an algorithm to narrow it down to one. So for example, if someone identified as a Pacific person, Maori and Pākehā, they would be recorded in all those categories, not just use the algorithm to say, oh, well, you're Maori. So it does add to more than 100%, just so when we get to the data, those of you who are mathematically minded don't start looking, going, hang on, what are you doing? Okay, now you might also say, are we comparing apples of apples? We are not. We're comparing apples of oranges, and that is the aim. This is a look at the differences. And the reason why the differences are important is because this might give us some insight into why so some of the reasons why we're seeing this different result. I'm trying not to use the word difference twice in a row. So Oars is technically for students with high to very high need in the education setting. It is open on impairment type. Disability support services is technically low to very high need. I say technically because if you look at the data, there's very few children in that low to medium camp. Most of them are in that high to very high camp. The reason for that is because it is restricted on impairment type to physical, sensory, intellectual and learning. And I think this does cross into this time period, increasingly autism spectrum disorder. ORS can be accessed a variety of ways through early intervention services, early childhood education, and the compulsory school system. Disability support services is provided through a network of need assessment and service coordination agencies, which is another terrible, unintuitive, well, it's an unintuitive name for whānau. It might make sense to the bureaucrats and us, because you go, well, that's what it does. But yes, it's and often these are just commonly called NASCs. So DSS is technically your support outside of the school setting. And of course, I haven't put it here, but DSS is, disability support services is all ages, and ORS is typically from age 5 all the way through to age 21. People can actually stay at school longer and frequently do. Now, we thought this might be important as well with on the ongoing resourcing scheme. Education professionals or other professionals often assist or even lead application processes. Technically, it's meant to be the parent, but I have been in the field in the front line long enough to know that there is a lot of assisting from schools and education professionals. The reason for this is there's a very strong incentive for schools to insist if they think the student needs support, because the support actually goes to the schools. So if you've got a student attending a school that you think needs support, there's a very strong incentive for you to actually assist that application process. NASCs are different. NASCs actually differ in name and approach. There are many different names throughout the throughout the country, run in very different ways as well. Some affiliated with DHB, some not. There's multiple types of NASC, just to make it doubly confusing for whānau. We've of course got under 65 disability support NASC. We've got over 65 NASC. We've also got mental health NASC. It can be harder to find out about the NASC process and how you apply, and I would argue there's less incentive for you to get assistance. So that's just some of the differences that I'm highlighting as possible reasons. You may have your own that you want to throw in there, or throw up in the comments afterwards or during. All right, so this is what we found. So on this first line is the estimated resident population for that age range in that year. Below that is disability support services. Below that is ORS. Oh, sorry. Also, disability support services is typically serves more children and young people than ORS. I don't have the numbers in front of me, but typically in this time period, it's probably something like 12,000 people accessing DSS and maybe about 8,000 accessing ORS. Don't quote me on that, but it's something to, in line with that ratio. So looking at this, we can see that, and I've got New Zealand European instead of Pākehā here because that's what the data says. So I thought I'd be consistent with the actual data. You can see that people accessing DSS are much more likely to be New Zealand European, 74.8%, which is way higher than the estimated resident population and way higher again than ORS. If we look at Māori, people accessing DSS is actually in line with the estimated residents population, and ORS is higher. Now we know from some of the from the disability survey that the disability rates for Māori, including Māori children, is high. And I won't go into that too much, but there is some disabilities that are of course associated with lower socioeconomic status, and there's a variety of sort of determinants there. There also is some issues I've got to say with the schooling system and some of our responses that tends to, yeah, that's probably getting into some difficult space, but there's a lot more sort of diagnosis of behaviour, challenging behaviour that personally I believe maybe a lot of it may be actually quite environmentally driven by how we organise things like our schooling system, but that's getting into separate research projects in itself. And so then we go to Pacifica, which is much lower for DSS and slightly higher for ORS. Once again, there's been a lot of problems with data collection in this area because of the low sample sizes we get for our household surveys that we tend to use for, such as the disability survey and others, and also, and this is once again getting into separate territory around our disability screening and identification questions. We actually use an international question set now, which I would argue perhaps doesn't give us good coverage of those communities because it doesn't quite gel with maybe the language or the way that they approach disability. I could go on and on about that. I was actually on the Disability Data and Evidence Working Group. I won't unless you ask me at the end, in which case it's your fault. And then going through, we see similar but slightly different patterns here where DSS is lower for Asian peoples, which is of course a huge conglomerate category, and similarly for Middle Eastern, Latin American and African, and although slightly higher on the other camp. And we see the was slightly more representative there. So let's just go on to another table, and there's actually graphs in the actual report if you prefer graphs. I just thought for doing this presentation, it was helpful to have the numbers. So this is looking at the difference between ORS and DSS in percentage terms. So as you can see there, New Zealand Europeans, DSS, its profile is much more likely to be New Zealand European, less likely to be Maori, and significantly less likely to be any of these other groups: Pacifica, Asian people, Middle Eastern, and Latin American and African. All right. Now, this is not an isolated result. I mean, while we kept this project relatively tight and focused, we have both a Better Start and ourselves and other groups have done a lot of other research, and this fits very familiar patterns we see. We see similar other inequity in other areas of disability support. In general, for stats in New Zealand data, we see lower personal and household incomes for Māori and Pacifica disabled people, as well as higher levels of income inadequacy. I have also crunched some data around the disability allowance. This wasn't using the IDI or source ranked ethnicity data, so it is a bit less reliable on that front, but still the trends were very consistent. So this is actually between taking a decade's worth of data, looking at from March 2010 to 2020. Sorry, it's a bit of a long sentence. And it's looking at median payment rates of the disability allowance. So for those that don't know, the disability allowance is a variable allowance. You put up costs up to a maximum of about 68, 65. And then based on the costs which are signed off by your GP and approved by work and income, you get a different amount each week. So New Zealand Europeans over that period have got a median payment rate of between $13.20 and $14. So throughout the entire period, their median was between that range. Yet if we look at disabled Māori, and so sorry, this is working age, though the data for over 65 shows similar inequity. For Māori, it was $8.55 and $10 a week, and Pacific people it was much, much lower at $5.60 and $6.40 a week. So this really does match that kind of overall picture we see, where we see inequity across a wide range of support types. And we also see that outputting into the lower personal and household income data. That's lower personal household income data comparing both Māori and Pacifica disabled people to non-Māori and Pacific disabled people, but also comparing them to Māori and Pacific non-disabled people, if that makes sense. So you see that inequity across all those comparisons. So clearly disability and disability-related inequality and ethnicity inequality clearly have that combination effect that leaves people worse off than if they were in either of those other camps. Right, what can we do? This is the part you wanted to cover. There's obviously system design issues that clearly need to be resolved. Yeah, I've got to say, having been involved in some of that work in the past, gosh, I hope we can do it, but it always gets bogged down. We'll find out more about whether Health NZ will be able to help here. Of course, next month, they're going to release, they're hoping to release how disability is going to fit in with Health NZ. So we have to see there. We've got the system transformation as well. I've been involved in other projects in the past that quite frankly have bogged down and gone nowhere. So yeah, we've just got to keep advocating there and keep pushing, but we also need to have, unfortunately, some realism that those are going to take some time well, I hope they don't take time, but that those are going to be difficult to address. I'll put it that way. But then there's also issues at the level of our individual practice, teams and services. And that includes for me as well, even though I'm in the exciting world of document control and support. There's a lot to think about here, even looking at things like emission processes and forms, how we outreach, how we operate our services in a clinical setting and non-clinical settings. And I guess pulling on that example there, I guess the question is, do we unconsciously expect conformity? When we look into it and we don't see the diversity of people accessing our services that we should see based on what we know about the community, I guess, what do we do with that knowledge? Do we critically think about how we can change what we offer, how we offer it, and who is offering it? Or do we perhaps, without really, in a more unconscious way, expect those people to change, expect those communities to change, to be more like the communities that do have better access at the moment, although not perfect access by any stretch of the imagination. And I guess that's the challenge. So even though that example was back in the 30s and 40s, I've got to say, I think some of that does still apply today. Are we critically thinking about this? So that's really the challenging part of it. And for my mind, there's always going to be that gulf in understanding. There's always going to be that learning process. So the problem isn't getting it wrong per se. The problem is they're not learning from getting it wrong, not doing the critical reflection from getting it wrong, and not having that quality improvement process to really pick up on that and take it forward. And I do also have a bit more of a wonky one here, which sorry, I had to put in because I've done a bit of work around the living standards and some of the well-being economic stuff. But and sorry, this is a bit wonky, this one. I had to throw one wonky thing in there. So do we consider how different parts of society are affected by our decisions and beliefs around the right balance of private and public costs, including time costs with disability? So what I'm really getting at there is a lot of our support, the way it's provided, the way it's accessed, is based on certain beliefs, certain political philosophy, certain political decisions or lenses you might apply to it about how we should balance private and public costs. Because this is always the perpetual thing with disability. Disability creates extra costs, extra financial costs, extra time costs. So the question from a policy perspective, from a society perspective, is how should those costs be met? Should they be met by the individual and their whānau, or should they be met by society, by the government? And that's, of course, always an active debate. I guess the challenge to throw out there is whether we have the diversity. Sorry, I've just got a colleague behind me. Hopefully it's not coming too much on the mic. Good. Okay. So we've got is thinking about whether we're properly considering the diversity community when we think about that. So when we think about that sort of whānau, are we thinking, for example, without once again being a bit unconscious about it, about say a Pākehā two-parent household with middle income, and then thinking about how that balance might be right for them? Or are we thinking about, say, and we know from the data, there is a large number, about 30% of households of disabled children are sole parent households. Are we thinking about households that might have less income, might come from a different cultural background? And are we thinking about sort of that stuff? So I'd make the argument that quite a lot of sort of support types like carer support, or even the child disability allowance and the disability allowance and actually disability support in general, is really aimed at thinking about that kind of generic household, that Pākehā two-parent household with perhaps even one or two incomes that are in the mid-range. Oh, yep, sorry. And
so Sam, I've wrenched away your.
Oh yeah, sorry, I'm over time, aren't I? I'm always over time.
That's great. You're obviously in the thick of it, and you think that we've got a lot of very smart and involved cookies here tuned in today and so I'm sure there'll be quite a few questions for you and things people would like to discuss. So team, open to you to either pop something in the chat box quickly or shout out, jump in and make use of Sam's expertise in this discussion.
Oh yes. Oh, sorry.
Sam, my name's Andrea Smart and I work for the Ministry of Education and hold a portfolio for complex needs on the ALS funded scheme. I see in the data that you've collected that Maori population is 29.1%, and compared that to New Zealand European, it looks low. But what we need to do is compare it with the percentage of population who identify themselves as Maori, because what we find with our statistics is that 1% of the school age population does access ALS, and that's a bit consistent year after year after year. So your data might show that we are potentially not supporting students who are Māori or Pacific, but actually with the percentage that identify with those ethnicities, it could be 1%. I'm interested to know your thoughts.
Wow, I mean, sorry, yeah, just oh no, I won't. Sorry, I won't bring it back up again. But you know that the percentage for oars was good. It was higher than the estimated residence population, if that makes sense. So Māori are more likely to access oars. Same with Pacifica. The percentages were actually quite good for oars. I know you guys might be used to being criticised all the time, so maybe no. The data actually shows oars. I mean, by no means perfect, and obviously there's issues around the total number of children who qualify. But in terms of ethnic inequality, oars is significantly better than DSS, and is significantly better than the estimated residence population, which sort of, as I talked about, is something we expect to see, but based on some of that Stats NZ data. So Oz looks good on diversity.
Thanks, Sam. So it sounds like a key message from you that I've taken up is there's the biggest differences in uptake of supports is when it needs to be primarily pushed forward by families themselves, and that's when the disability support services. And what we can do differently about that, you've talked quite a bit at the service design level, which is quite fundamental. I wondered, you've talked about making all of the inroads into accessing the supports easier for people, more facing of the person who would be making use of those services and finding out about them, rather than bureaucratically focused that work for the system itself and the providers. I also wondered about literacy and differences and how much that might be a barrier to accessing the systems itself and the allowances.
Yeah, I mean, look, there's a wide variety of oh, sorry, I do respond to one of the chat questions too that says that's a lot of paperwork for an extra $5.60 a week. It sure is. Jeez, yeah. So there is some good research showing that support can be often easier to access for people in lower socioeconomic situation, and that's not just around time or the financial resources. That's also around, if you're stressed and if you're in a position where you're facing a lot of multiple forms of discrimination, it's just actually harder to do a form. You know, it's harder to go through. I mean, look, I mean, taking it out of this setting entirely, if I'm reviewing a form, say, I don't know, about an adverse event reporting, you know, a way to adverse event, it's a very different experience for me writing up a form for how someone will report an adverse event compared to someone who's going to fill that in who was part of that adverse event and was deeply affected by that and is feeling, you know, got a lot of challenges around that. It's just a fundamentally different experience. So what happens is all these processes impose a lot of costs, time costs, and also knowledge costs, and also require literacy, a lot of, and if you're experiencing multiple forms of disadvantage, that's going to make that progressively harder and harder and harder. It's not easy for anyone, but for those groups who perhaps are in a less stressed position because they're not experiencing a lot of this, it's going to be easier to jump through the hoops required. So I think that's what you are seeing. So it is all that stuff, and it is about the design of the admission process. And yeah, I mean, this applies to disability support services, but I think it applies across the board really to you know, access into the clinical services and the non-clinical services and all the varieties of social support and NGO support as well. I would expect to find, I mean, look, as a hypothesis, I would expect to find the more steps there is in the process, the more inequity you're going to get in terms of who gets through. would be
Thanks so
my
much, Sam.
hypothesis.
A well-informed one too. Thanks so much, Sam. I've just flashed up that what's happening next month. For those of you who didn't catch it at the beginning, we'll be doing a facilitated discussion of specific immediate changes that we can impact in whatever roles that we have and at multiple levels around improving the equity of access to support for people of different ethnicities. So ka kite anō, thank you everybody, go well, and we look forward to seeing you again next month or the after that. Thanks a lot.